Hi everyone, so I am Dr. Saurabh Dixit and today I am going to present you a very important case, and that case is a patient who is having a long right-sided thyroid nodule, and this thyroid nodule is 7 to 8 year old, and now this is also associated with the complaints of dysphagia, dyspnea and hoarseness of the voice. So before that, let us understand the concept of thyroid nodule. When we talk about the goiter, and the thyroid nodule, the two things are totally different. A thyroid nodule is an isolated increased size of, you can say, tissue in the gland. And what is a goiter? The goiter is enlargement of the gland. So increased size of gland. So we have a patient today who is presenting to us with a long thyroid nodule. When we talk about the nodule, what is the biggest concern? What is the biggest concern for us? So whenever we have a thyroid nodule, let me tell you the 2 or 3 important things. The first important concern is whether it could be a cancer or a malignancy. And for that, the most important thing is that we need a confirmation. How do we confirm? For confirmation, the gold standard that we have is FNAC. But now the problem is majority of the thyroid nodules could be a colloidal nodule or maybe a heterogeneous nodule. What do you mean by a heterogeneous nodule? There could be a solid and there could be a cystic consistency. So if you go for a blind FNA, what can be the problem? You can aspirate from the colloidal part and you can give a negative result. So what do we do? In order to add the sensitivity, we go for a USG guided FNAC. So USG guided FNAC is now what is the protocol. Now when we talk about USG, what advantage does the ultrasound has? Ultrasound will not only have a reduced incidence of false negative reporting. So the false negative reporting, this has been minimized. And the second very big advantage of using is simultaneous assessment. Remember, in a nodule, something which is tall than wide. So if it is taller than wide, this is associated with increased risk of malignancy. Second is, if there is increased internal vascularity. So if there is increased internal vascularity, then also. The third is, if there is microcalcification, if there are irregular borders, or if there are lymph nodes present. So these are the features that are to be looked for. Along with that, clinical history is also very important. What are the important points in the clinical history? When we talk about the clinical history of a patient, always remember the gender. The rule of the gender is thyroid nodules are seldom seen in males, but if seen, they are seldom benign. So in males, there is increased risk. Then age of the patient is again a very important criteria. Age more than 40 years is always indicative of malignancy or should be accepted as malignancy unless proven otherwise. And then the size of the nodule. The size, if it is more than 4 centimeters. One more thing is, if you go for a radioactive scan, you will get to see whether it is a cold or a non-functional nodule. The cold nodule, if you talk about cold nodule, 15 to 20% of them are malignant, and in this case, hot nodule is 5 to 10% of malignancy is seen. Along with that, when we talk about age, we have a bimodal pattern. Age more than 40 years or less than 15 years. Remember, thyroid nodules are seldom seen in kids, but if seen, they are seldom benign. One very important thing is the history of radiation. Now, what is the history of radiation? Radiation is a slow killer. And remember, if you are exposed with radiation today, you will have the cancer developing after maybe second decade or third decade. So 20 to 30 years later. Now you cannot ask patient that were you born in Hiroshima and Nagasaki? How do you get to know that female has or patient has undergone a treatment or has undergone radiation exposure? The first thing is you will ask whether you have undergone any treatment for acne or maybe hair removal. So that is the place where the radiation comes in day-to-day practice. So now I will take you to direct patient and we will do the assessment of the patient. So hi everyone, now I am going to take you to the patient, and we have a patient who is 52 years old with a nodule on the right side, and let me take you to the patient. So hello, she is my patient, and you can see that there is a nodule, there is a big nodule on the right side of the gland, right side of the neck. Basically this is starting from one side of the sternomastoid and extending up to the other border of the sternomastoid. So आप ये बताएंगे कि ये कितने दिनों से था आपको? So it's a long standing history. So the first thing, students, that we have to understand is whether this neck nodule is a thyroid swelling or is a swelling which is associated with maybe a thyroglossal duct. First of all, clinically seen, this is not the persistent thyroglossal duct, it's a thyroid swelling. But let us confirm it. How will confirm that it's a thyroid swelling? आप एक बार पानी पीजिए. So you'll ask the patient to swallow. When the patient swallows, can you see with the deglutition the swelling is moving up? Can you do it again? एक बार फिर से. Yeah. So just see, with the swallow, the swelling is moving. So why this happens? Because this is enclosed under the pretracheal fascia, and with the deglutition movement, this is moving. Now try to understand. We have to confirm that this is not a thyroglossal duct cyst. So you will ask the patient to take the tongue out. आप एक बार अपनी जीभ बाहर निकालें. With the protrusion of the tongue, the swelling is not moving. With deglutition, it was moving. So this is the swelling. Whenever you are going for assessment of thyroid, you have to see the swelling from the front, so that you don't miss out any scar, any lesion external to that. Also, you have to take the swelling from the lateral side. So you'll ask the patient to extend the neck laterally. So you will see the swelling laterally. From the lateral, you can see the bulge and you can see the contour. Now, whenever you want to examine, there are a lot of methods of examination, but what is preferred is to go from the back. Remember, the pulp of your fingers are going to help you. So if I want to, I will have a feel of the gland. I am seeing that there is a cystic swelling over the gland. So since this is a swelling of the right side, I will take it a bit, I'll give a bit lateral traction with my left finger, and this is the nodule, and here I am trying to assess the surface, the nature, whether there is any palpable groove behind or no. Along with that, I have to assess the neck nodules also. So there are no neck nodules, there are no lymph nodes, so this is not having any lymph node. Along with that, you have to check whether there is any symptom of retrosternal extension or there is any symptom of hoarseness. आपकी क्या आवाज पहले और अब में कुछ बदलाव आया है?
1 week से थोड़ा सा.
Okay. So patient has a recent history. कैसी होगी? भारी होगी?
हल्की सी, मतलब दवा कुछ बदली सी.
भारी जैसी लगी.
जैसे थोड़ी वैसी हो रही है, जैसे लहर.
So patient is having a recent onset of hoarseness of voice. Now the patient is, now we can do a percussion over the manubrium to see whether there is a retrosternal extension, but there is one more clinical method of doing a retrosternal extension, and that is a Pemberton sign. So now I will show you the Pemberton sign for the retrosternal extension. So this will help us understand whether the thyroid has gone behind into the mediastinum. आप दोनों हाथ ऊपर करेंगे, and this way you ask the patient. This is a Pemberton, and we have to wait for 1 minute. आपको 1 मिनट तक ऐसे रहना. Now what we are going to look for, if there is a retrosternal extension, there will be a blockage to the blood vascularity of the neck, and there will be facial congestion. So now patient is complaining of distress. आपको कुछ तकलीफ लग रही है? Yeah. Pressure से feel हो रहा है. Okay. So that means this patient is having some difficulty. This is not an exactly a retrosternal extension. ठीक है, आप आराम हो जाइए. But since the mass is huge, the patient is having that Pemberton-like feeling. Okay, so there is some congestion, but this is not purely a retrosternal extension. Had it been a retrosternal extension, the patient would have really had a very congested look with the things. Now we also have to look for certain signs of hyperthyroidism. Clinically, the patient is not having any history of hyperthyroidism. Patient is euthyroid, but still you can see the eyes. You can see the eyes. There is no exophthalmos. There is no exophthalmos. Now there are two ways of looking at for exophthalmos. This is one way you can look, or you can also ask the patient to flex the head. So this is a Nevzigers method. Had the patient been having exophthalmos, that would have been directly visible under the direct vision. So there is no exophthalmos for this patient. Now students, what should be the ideal approach? We have undergone a USD guided FNA, and USD guided FNA has suggested a right-sided choroidal nodule with some heterogeneous ecotexture, and we have planned a hemithyroidectomy for this patient, and we will follow you in this patient with the surgery demonstration also. Thank you for watching.